Mr. Siddharth Kamath, one of mentors with Orthopaedic Academy. Topic of Viva is Physis. You'll be shown a slide which shows either X-ray or a illustration of Physis. Like in this case, you can see a distal femur with open Physis. This is a start of discussion and does not carry any mark. What are the questions possible in this case? What is Physis? Physis is a cartilaginous structure which is responsible for endochondral ossification of bone. What are its functions? The functions lie in the definition itself. It is involved in the endochondral ossification and growth of the bone, both longitudinal and appositional. What is structure of Physis? This is a very important question and you should be able to describe it very correctly. There are various zones in Physis starting from epiphysis to metaphysis. First zone is a reserve zone which has got cells with lipids, glycogen and proteoglycans. The second zone is called proliferative zone. In this zone, the cells proliferate, become bigger, and they get stacked together. Hence, they are arranged in one line. This zone has a high oxygen tension. Next zone is called hypertrophic zone. In this zone, the cells become bigger and bigger and finally rupture. Hence, hypertrophic zone is divided into three zones. One is maturation zone, second is degenerative zone, and third is zone of provisional calcification. In maturation zone, the cells become much bigger, whereas in degenerative zone, they have a lot of matrix and a lot of calcium. In zone of provisional calcification, they burst up and throw all the calcium matrix into the interstitium. In this zone, the cells also give collagen number 10, which is very important factor in provisional calcification. Next zone is when actually ossification starts, and it is divided into primary spongiosa and secondary spongiosa. In primary spongiosa, there's a vascular invasion, but there's no remodeling. Whereas in secondary spongiosa, there's a remodeling occurring in the bone. Next question can be, how does the ossification occurs? As already I've described in structure, ossification occurs because of sequential rupture of cells, giving the matrix, calcified matrix, which is invaded by the osteoblast and osteocytes. How much growth occurs in Physis? Physis is a quite active part in the bone. However, some Physis are more active than others. For example, proximal humerus, distal radius, distal femur, proximal tibia are very active. If you consider the lower limb, which is really important, then lower limb grows at 23 millimeter per year, out of which 3 millimeter occurs in proximal femur, 9 millimeter in distal femur, 6 millimeter in proximal tibia, and 5 millimeter in distal tibia. The growth continues to around 12 years in girls and 14 years in boys. Another important question which can be asked. Another important question that can be asked is, what are the conditions affect Physis? There are various conditions which can affect Physis, like Gaucher's disease, a storage disease that affects a resting zone, whereas achondroplasia or gigantism affects proliferative zone. Sufi, rickets, and chondromas affect hypertrophic zone. Whereas in primary spongiosa, you can get a renal rickets. In metaphysis, you can get osteomyelitis. Next question is, what are the other conditions? Sorry, cut. You can also tell that physis can get affected because of traumas. Cut. You can also say that physis can be injured because of trauma, giving rise to various cut. You can also say that physis can cut. You can also say that physis can get injured, getting various physial injuries, injury, ischemia, and infection can cause physial arrest. Certain physis are intra-articular, like in shoulder, hip, elbow. And if there is a cut, certain physis are intra-articular, like shoulder, elbow, hip, and ankle. And whenever there is a septic arthritis affecting this joint, it can destroy the physis. As well, a osteomyelitis can lead to septic arthritis. What are ways to correct limb length discrepancy? It's an advanced question. Limb length discrepancy can be because of number of factors. One of them can be physial arrest. Physial arrest can be also used as a therapeutic mode to correct limb length discrepancy. It's very important to know the limb length discrepancy that might remain at the maturation. If it's less than 2 inches, sorry, if it's less than 2 centimeters, nothing is done. If it's 2 to 5 centimeters, the contralateral limb is shortened. If it's more than 5 centimeters, the ipsilateral limb is lengthened. If it's quite big, like more than 20 centimeters, we have to consider amputation. If it is more than 20 centimeters, we have to consider amputation and prosthetic fitting. Thank you. Hello, I'm Siddharth Kamath, orthopedic mentor, working with the Orthopaedic Academy. Topic of Viva is muscle. You'll be shown a picture or illustration of muscle, or it can be anything else. And it's starting question which opens the discussion. Look at this picture. You can see the femur and attachment of adductors to it. So what is muscle? Muscle is a connective tissue made up of contractile proteins, which has functions of locomotion, maintenance of posture, and generation of heat. The various questions which can be asked are, what is structure of muscle? Examiner is asking you, what is the gross structure of muscle? So individual muscle is encapsulated in a fascia called epimysium. And under this epimysium, you got small groups called fascicles. which are lined by perimysium. And the fascicles, there are muscle fibers which are surrounded by endomysium. Each muscle fibril has got myofibers, which are individual cells. And each myofiber is made up of myofilaments. So what is the microarchitecture of muscle? So there are two important proteins. One is actin, which is thin one, and other is myosin, which is thick one. You might be told to draw the microarchitecture of muscle. So you have the M line in which the myosin filaments are attached, and a Z line where actin filaments are attached. There is an area in which actin and myosin filaments overlap. This is called a line, whereas the area where there's only myosin filament is called H band. Area where there's only actin filament is called I band. Next question can be, how do muscle contract? The key word here is you have to tell muscle contract with excitation, contraction, coupling, which means that at myoneural junction, when the action potential arrives, there is a release of acetylcholine into synaptic cleft, which work on the ACH, that is acetylcholine receptors, and opens the sodium channels. This causes depolarization of the sarcolemma, which is a membrane over each muscle fiber, and which in turn depolarizes sarcoplasmic vesicles, which contains an action potential which is sarcoplasmic retinaculum, which has storage of calcium. It releases them into interstitium. When it releases, there is a configurational change in troponin, which in turn causes configurational change in tropomyosin and exposes the myosin binding sites on actin. So they link to each other, and you require ATP to unlock it. So ATP is actually required to unlock the two filaments so that they can slide. And this is called sliding filament therapy. Next question can be, what are the types of contraction? Contraction can be either isometric, where the length is same and tone increases or decreases. It can be isotonic, when tone remains same and length increases or decreases. Or it can be isokinetic, which has reference to speed, in which it contracts with a constant speed. Or it can be plyometric, in which there is a rapid lengthening followed by rapid contraction. Further, contraction can be either concentric or eccentric. A contraction is concentric when it shortens during contraction. For example, when you do bicep curl, biceps contracts as the elbow flexes. Other contraction is called eccentric contraction. This is a contraction when muscle actually lengthens to control a jerky movement. For example, if you hold a weight in the hand and try to extend, it doesn't go in a jerky fashion, but it goes in a very well-controlled fashion. This is because biceps has contracts at the same time lengthens, preventing a jerky movement. Few applied questions about muscle. What are the various drugs which can work on muscles? There is a botoxin poison which prevents presynaptic release of acetylcholine and hence does not allow the muscle to contract. There are muscle relaxants often used by anesthetic colleagues. They can be depolarizing agent like succinylcholine, which acts as a partial agonist to acetylcholine, or non-depolarizing edit please, or non-depolarizing edit please, or non-depolarizing agents like atracurium, which is a competitive inhibitor and blocks the acetylcholine by blocking the receptor. Next applied question can be what correction edit please. Next applied question is what happens in muscular dystrophy or myasthenia gravis. In muscular dystrophy like Duchenne's type, there is absence of dystrophin protein, which is a structural protein which connects actin to the lamina of the cell membrane. Because there is no support, muscle cannot contract that efficiently and slowly fatigues and gets paralyzed over the years. What happens in myasthenia gravis is a bit different. The acetylcholine receptors are destroyed by autoantibody. Hence, acetylcholine does not have place to work on and paralysis occurs. This affects a rapidly acting muscle like eye muscle. There can be various other questions which can be asked on muscles, like what are the types of muscle fibers? They can be red fibers which use oxidative metabolism, which is responsible for slow and endurant movements, or they can be fast twitch fibers which has anaerobic metabolism and they are used for rapid short-lived movements. Thank you. Hi, I'm Siddharth Kamath, a mentor with the Orthopaedic Academy. Topic of Viva is bone. This is a basic science Viva. Look at this picture. What can you see? The illustration in front of me shows femur, a long bone. What are the questions which can arise from this starting slide? Starting slide does not have any marks, but it starts the discussion. So what are the questions which goes as per the level of the difficulty? First question might be, what is bone? Bone is a rigid composite connective tissue structure. Add it again. Bone is a rigid composite connective tissue structure. Next question will be, what are the types of bones? Bones can be classified as per their shape as long bones, short bones, flat bones, irregular bones. Each one has its examples, like femur is a long bone, metacarpal is a short bone, scapula is a flat bone, whereas vertebrae is irregular bone. Bone can be also classified as according to the microarchitecture as either immature bone, in which the bone and matrix is scattered without any orientation towards the stress lines. This can happen in fracture callus or in certain malignancy having a reactive bone. It can be a trabecular bone, often seen in cancellous bone or in medullary bone. The bone here does form a weak structure aligning as per the lines of stress, but it's not a rigid structure. It has a high turnover and low Young's modulus of elasticity, whereas other type is trabecular bone. It has a rigid structure. It has a low turnover and high Young's modulus of elasticity. If you look at this trabecular bone, it is made up of various osteons or Haversian systems. Haversian system has a central canal having artery, vein, and nerve, and concentric layers of osteocytes. Osteocytes are connected to each other by canaloculi and communicate with each other at gap junctions. In between them is matrix, and surrounding these concentric layers is cement lines. The cells of bone are of three types: osteoblast, which come from osteoprogenital cells. These are active cells, and its function is to secrete proteins like collagen, osteocalcin, osteopoietin, and osteonectin, and proteoglycan, and to signal the osteoclast. They either become inactive or turn into osteocytes or undergo apoptosis. Coming to osteocytes, osteocytes are relatively not so active cells, but it is an important part in mineralization of matrix and calcium phosphorus homeostasis. The third cell is derived from macrophage lineage. It has multiple nuclei, it's bigger than in size, and most important, it has got ruffled border. Ruffled border when it ruffled border when it touches the bone matrix forms house-shaped cannula, which are the sites of bone resorption. Bone resorption occurs in two ways. Osteoclast secrete cathepsin K, which dissolves the organic component, and also enzymes like acid phosphatase and carbonic anhydrase, which dissolves the inorganic component. Next question can be, what are the functions of bone? Bone has got various functions like maintenance of posture, first P, propulsion, second P, proprioception, third P, production of red blood cells, fourth P, provision of calcium and phosphorus, fifth P, and last but not the least is protection of internal organs like lungs and heart or spinal cord. Let's go to the next question. What is the composition of bone? Bone is a composite structure. A dry weight of bone has got 40% organic matrix, which is made up of collagen and proteoglycan, some elastin, and other proteins like osteocalcin, osteopoietin, or osteonectin. Whereas inorganic component, which is 60% of dry weight, is made up of hydroxyapatite or tricalcium phosphate, which is called prusside. The organic component, mainly proteins and collagen, gives tensile strength to the bone, whereas inorganic component gives compression strength to the bone. Bone is a structure which is strongest in compression, weak when it is pulled apart or by tensile forces. Correction, edit again please. Bone is a structure which is strongest in compression, weaker in tension, and weakest when shearing forces are applied to it. Bone develops by two mechanisms: endochondral ossification and intramembranous ossification. Of endochondral ossification is femur. An example of intramembranous ossification is scapula. What are the factors that affect bone? There are mechanical factors like the forces on the bone, compressive and tensile forces. Wolff's law states that bone remodels as per the stresses it gets, whereas Utel-Volkmann's law, whereas Uter-Volkmann's law states that compression increases the bone formation, whereas tension decreases bone formation. Hence, bone in a hip is more in calcar, which is weight-bearing area. The biological factors are vitamin D. Vitamin D has two effects. One is reabsorption correction. Vitamin D has three effects: mineralization of bone and reabsorption of bone. It mineralizes bone by acting on osteoblasts and osteocytes, causing deposition of minerals, whereas it also causes reabsorption by same way. It acts on osteoblast, which send cytokines to osteoclast and reabsorb bone. Another important hormone is parathyroid correction. Another important hormone is parathormone or PTH. It works on osteoblast, which in turn activates osteoclast by a Rankel pathway that causes reabsorption of bone. Other hormones are calcitonin, which inhibits osteoclast, estrogen, which inhibits osteoclast, and steroids, which reduces bone formation by inhibiting, which inhibits the bone formation by inhibiting the protein synthesis. Last but not the least questions: what are the drugs acting on bone? Other than vitamin D, parathormone, other important drugs you should tell is alendronate, which are commonly used. Alendronates inhibit osteoclast and hence reabsorption of bone, and it's commonly used drug in osteoporosis. Thank you. Hi, I'm Siddharth Kamath from Orthopaedic Academy. The title of Viva is Non-Union of Fracture. Look at this illustration. This is a picture which shows a non-union of tibia and fibula with Eliza row frame in situ. So what are the questions that can arise? What is non-union? A simple definition of non-union is that it is arrest of process of fracture healing. There is a famous FDA definition which says that fracture has gone into non-union if 9 months have passed and there is no sign of healing for last 3 consecutive months. So next question comes is, how does a fracture heal? Fracture heals basically 2 ways. It depends on the mechanical stability and strain at the fracture site. If strain is less than 2%, then it heals by primary healing. It is a process of intramembranous bone formation in which there is a direct deposition of bone. If strain at the fracture site is between 2 to 10%, then fracture heals by secondary healing. It is a type of endochondral ossification which has phases. It starts with stage of hematoma formation and inflammation, stage of repair, which is formation of soft callus and then hard callus, and stage of remodeling. An important question asked at this point is, what are the factors that affect non-union or that cause non-union? There are general factors, there are fracture factors, and there are surgical factors. General factors are if the age is advanced, if the bones are weak, like in osteoporosis, if there are chronic inflammatory diseases, some drugs like steroids, quinolones, NSAIDs, lifestyle like smoking, infections like HIV, are the general factors. The fracture factors is if the fracture is open, there's a loss of hematoma formation and it delays the fracture healing and sometimes stops it. If the soft tissues are crushed or traumatized, like in compartment syndrome, in which the blood flow to the bone becomes less. If the fracture itself is comminuted, if the fracture is in a crucial bone which has less blood supply, like scaphoid, talus, neck of femur, etc. What are the types of non-union? There is a atrophic type of non-union which is characterized by the obliteration of medulla, sclerosis of the fracture site, and obvious fracture, that is gap. There is a biological failure in this case, that bone has got stability but does not have biology to heal the fracture. Hypertrophic type is the non-union in which bone does have the capacity, and that's the reason it is characterized by exuberant callus. However, the fracture is still there as a gap. This happens when the stability is there, but not enough to cause healing. But the bone has biology, it has viable ends. Third type is oligotrophic non-union. In this case, there is stability and there is viability of bone ends, but the reduction is poor and there is a scanty formation of callus. The non-union can also get complicated by infection, in which there is, in addition to various things, there is a destruction of bone ends. There can be other features like formation of sequestrum, lysis of bone, etc. Over the time, if the fracture really does not unite, then it can go in two end stages, either a fibrous non-union or a pseudoarthrosis, which is a formation of a false joint with a pseudocapsule. How do you treat non-union? It's a very easy question actually. You have to look at the general factors and rectify that. Look at the local factors. See what type of non-union it is. If it is a hypertrophic non-union, then all that it needs is stability. If it's oligotrophic, then it will require reduction and stability. If it's atrophic type, it will require stability as well as some augmentation, like with bone graft. If it's infective non-union, then we have to have the debridement of the non-union to take out the infective tissue, get a culture and know the bacteria and needs antibiotics, and in addition needs stability. A important technique which is used in infective non-union is Irizarro ring fixator, which helps you to debride the fracture, maintain stability, and also augment it by process of bone transfer. Wait for slide to load, please. Correction, start. Infective non-union needs debridement, culture of material and antibiotics, in addition to stability and augmentation. An important technique is Irizarro. Correction, an important technique is Irizarro, which helps debridement and the gap is filled with bone transport. It as well gives stability to the fracture. So what is bone graft, which we need to use in atrophic non-union? Bone graft is a material that helps bone formation. It is used in non-union of fracture, in fusion of joints, and in filling gaps when we have removed something. For example, like a benign tumor. Types of bone graft can be either autograft or allograft. Autograft is from the same person, whereas allograft is usually from cadaver. Allograft can be fresh, frozen, freeze-dried, whereas autograft is usually fresh. Allograft is good to get correction. So what are the types of bone graft? It can be autograft from the same person or allograft, usually from cadaver. It can be cortical or cancellous. Allograft is important because it can give a lot of bone, like in revision surgery of hip replacement or knee replacement, we use structural allograft. However, they have some antigenicity and can transmit infection. So why is bone correction? So why is autograft better? Autograft is better because it has all three properties. It is osteoconductive, that is, it forms the framework. It is osteoinductive, it gives the factors which require for bone formation, as well as it is osteogenetic. It got cells which can form bone. The cells are mesenchymal cells, osteoblasts, and osteocytes. Other than this thing, the other material which can be used as bone graft substitute are factors like bone morphogenic protein 4 or demineralized bone matrix. There are also some synthetics which can be used, like calcium phosphate, calcium sulfate, hydroxyapatite. And there are certain physical modalities like electricity, that is pulsed or direct current or ultrasound. Thank you. End of I'm Siddharth Kamath, mentor with Orthopaedic Academy. Topic of Viva is cartilage. Look at this picture. What can you see? This is an opening slide and does not carry any marks, but it opens discussion. It's very important that you identify and name it first and then describe, rather than going other way around. What are the various questions which can be asked in this station? What is articular cartilage? Articular cartilage is a structural connective tissue which lines ends of the bone to form synovial joint. It has properties like it is avascular, aneural, and alymphatic. Cartilage can be of various types, like hyaline cartilage in articular cartilage. Cartilage can be added again, please. Cartilage can be of various types. Hyaline cartilage is a articular cartilage. Fibrous cartilage is present in structures like menisci. It has high level of fibrous tissue. Whereas elastic cartilage is present in ear and it has high level of elastin. Physis is also a cartilage, a specialized cartilage. What are the functions of an articular cartilage? Articular cartilage have various functions like load bearing, distribution of load, absorption of load, which is also called shock absorption, and lubrication. You'll be asked to define, describe, or draw microstructure of cartilage. So articular cartilage has got 3 zones: superficial, middle, and deep zone. The collagen fibers forms arcs to give the structural stability to the cartilage. So coming back to zones, superficial zone has got flattened chondrocytes and parallel arrangement of collagen. It has highest amount of water. Whereas middle zone, which is thickest zone, has got oblique collagen fibers and randomly placed chondrocyte. Whereas deep zone has got chondrocyte arranged in columns and perpendicular arranged collagen fibers. Collagen fibers in hyaline cartilage is collagen type 2. After this zone comes tide mark, which separates it from the subchondral bone. Subchondral bone is vascular, whereas cartilage is avascular. It derives its nutrition from synovial fluid. How does lubrication occur is a very common question. There are various types of lubrications that occur depending on the range of movement and loading of the joint. It can be boundary lubrication, which is a fluid separating 2 slippery surfaces. It can be hydrodynamic lubrication, in which the fluid which separates the surfaces deforms at various places. It can be elastro-hydrodynamic, in which surfaces also deform with the fluid and give lubrication. It can be boosted when fluid changes its density, or whipping, in which the articular cartilage throws fluid inside the joint and gives lubrication. So as I said, the type of lubrication depends on the range of the joint as well as the loading of the joint. So coming to next question, which is again important and advanced question. What is difference in arthritis versus aging? In aging, cartilage becomes stiff, whereas in arthritis, it becomes more elastic. In aging, chondrocyte become bigger, but the numbers become less. However, keratin to chondroitin ratio is increased. There is increase in collagen fibers. Whereas in arthritis, as it becomes more elastic, there is increase in water content, chondrocyte increase in number, collagen fibers increase in number, but they are disorganized. Another important question which is often asked is, how does cartilage heal? If the injury to the cartilage is below tide mark, then blood flow has a place to go and forms a replacement cartilage. How does cartilage heal? It's a very important question. So if the injury to the cartilage goes deep to the tide mark, it heals by forming a fibrous cartilage. Whereas if the injury is not gone till the tide mark, then cartilage does not heal. All that happens is chondrocyte get proliferated. So to round up, cartilage is a very watery structure, has got around 70% of water, 5% of cells, which are chondrocytes, 10 to 15% each of collagen type 2 and proteoglycans. Thank you. Start of Fiverr. Hi, I'm Siddharth Kamath, orthopedic mentor from Orthopaedic Academy. Title of Fiverr is Tendons. Look at this illustration. You can see dissected arm specimen. Point of interest here is triceps tendon. The questions that can arise in this session are, what is a tendon? Tendon is a structure that connects muscle to the bone. It has functions of creating a movement and maintenance of posture. What is composition? Tendon contains type 1 collagen, which is 85% of its dry weight, proteoglycans, which are 5% of its dry weight. It has got some elastin and some lipids. It has tenocytes, which are modified fibroblast, function of which is to produce the protein, that is collagen. What is structure? Various fascicles of tendon are embedded in endotenon, and all these fascicles are lined by epitenon. Tendon arises from the musculotendinous extension and it inserts from the bone. It inserts two ways. One is by fibers called Shapley's fibers, like in deltoid or adductor tendons of thigh. It can also insert with a phase transition. That is, at a point of insertion, tendon changes to non-calcified fibrocartilage, then calcified fibrocartilage, and then bone. This structure is seen in rotator cuff and tendon Achilles. What are biomechanical properties of tendon? Tendon is strong in tension but weak in compression. It buckles down with compression. However, it can take higher loads. It is, however, less viscoelastic than ligament. When you load a tendon, you will see a toe region which is uncrimpling of fibers. And then as the stress rises, the strain rises, and when it reaches the ultimate tensile strength, it shows sequential failure with various peaks occurring in the failure region. One important question is, how does tendon differ from a ligament? Ligament is a structure which connects bone to bone, whereas tendon is muscle to bone. Ligament has function of restricting the joint movement, stabilizing the joint, and proprioception, whereas tendon has a function of moving the joint. Ligaments have lesser collagen, more of proteoglycan, more of elastin, and fibers are arranged in not really stress-oriented fashion, whereas tendons have the fibers arranged in very orderly and stress-oriented fashion. This gives the ligaments a slightly different biomechanical property. It makes them more viscoelastic. It shows creep, stress relaxation, and hysteresis. Hysteresis is a phenomena in which the loading and unloading gives two different curves. The resultant is loss of energy, which often in body gets released as heat. Another important question is how the tendons fail. Tendons can fail two ways. One, by a single traumatic event, a macro trauma, or it can be multiple micro trauma causing a fatigue failure. So it can be a traumatic failure or a attritional failure. How do the tendon heals? Tendon heals if properly opposed to various stages, like stage of inflammation, which starts with the hematoma formation, lasts for around 7 days, stage of granulation or proliferation, in which the cells start depositing proteins and trying to heal itself. The collagen which is deposited at this stage is collagen 3, which gets replaced by collagen 1. Last stage is stage of remodeling, which starts after 21 days and gets over by 6 months. However, tendon continues to get further strength almost up to 1.5 years. A repaired tendon is weakest, a repaired tendon is weakest between 7 to 10 days. This is a very important point and will be asked in examination. The factors which help tendon healing are surgical factors, tendon factors, and general factors. General factors is younger age, good nutrition, good mobilization, helps healing, well as old age, chronic inflammatory diseases, steroids, drugs like NSAIDs, smoking, delay tendon healing. But there are some things in the structure of tendon itself makes a lot of difference in healing, and that's why tendon Achilles can be treated conservatively, whereas flexor tendon injuries are not. The reason of that lies in this. If you see at the gross structure of tendon. Tendon is got a peritoneum which covers it all the way, and you have a longitudinal artery which gives a rich blood supply, like in tendon Achilles. Or it can be a sheath tendon. You can see it sheaths almost all around, and in the stalk you have the artery. This stalk is called vincula, like in flexor tendons. So this is the reason the tendon Achilles tend to heal well, where the flexor tendon does not heal that well. Another important diagram in this viva is this. You can see the stress strain curve of tendon. You can see the toe region, and the strain in tendon rises, goes to ultimate tensile strength, and then goes sequential failure. This is because one by one fibers fail, not all at once. Thank you.